Welcome everyone to today's webinar. I'm Emily Rapley, Managing Editor with Becker's Hospital Review. We will begin the webinar today with a presentation and we'll leave time at the end of the hour for a question and answer session. You may submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will send a copy of the presentation to the email you used to register. Now it is my pleasure to introduce today's presenters, Kate Harper and Daniel Graves. Kate Harper is Senior Vice President of Payer-Facing Shared Services at R1. Kate has more than 14 years of experience in hospital revenue cycle consulting and management. She has spent her career in a variety of PFS and revenue integrity roles, focusing on process improvement and project management. Daniel Graves is Vice President of Coding Operations at R1. Dan has led the coding division since 2015. Prior to his leadership role in coding, Dan headed numerous revenue cycle and client experience divisions, enhancing patient access, patient billing experience, and AR. I'll now turn the floor over to Kate to begin today's presentation.
Good afternoon. Thank you all for joining. We're going to spend some time today talking about revenue cycle outsourcing, some of the trends and proven plays we've seen for hospital leaders. Skip past our headshots and start with the challenges we're seeing today. Today's health systems are facing significant challenges across the marketplace, including more complexity in healthcare rules and payer contracting, higher costs, lower margins, more patient consumerism, and less access to capital to enhance the technology platforms to solve some of these challenges. Healthcare organizations face significant financial challenges with declining revenue yield, high costs to collect, inefficient commercial operations, capital constraints, and increasing transactional complexity. Actually, Moody's just recently restated a dire outlook for not-for-profit hospital sectors, citing the high number of bankruptcy protection filings in light of all these challenges. In addition, in recent years, hospital revenue cycle leaders have seen an unprecedented rise in that consumerism and patient experience space throughout the healthcare industry. What we'll talk about today is to address these issues, hospital leaders are looking at all sorts of ways to improve financial processes, implement more advanced technology, and enhance the patient experience across the settings of care. Systems can't continue throwing more people at the problem or just trying harder. It's getting too complex and too narrow in the margin space. 75% of hospitals have started outsourcing at least some part of their revenue cycle, something like coding, patient receivables, or revenue optimization. Doing this allows access to advanced subject matter expertise and revenue enhancing technology, which is some of what we'll talk about throughout this presentation. Some main reasons and drivers for the move to outsourcing are highlighted on this page: reducing operational expense, increasing performance metrics, cash, yield, improving the experience for the patient, for the physician, for revenue cycle staff, and gaining expertise at scale for those ever-changing payment models, regulations, technology, and automation opportunities. They're looking at all these increasing cash as a percent of their AR, decreasing AR days, decreasing DNFB days, decreasing aged AR. All of these are indicators and outcomes that outsourcing could help with. Today we're going to focus on three main outsourcing plays: co-managed, end-to-end, and strategic focus areas. Before we get into them, we're seeing health systems now starting to view revenue cycle as a competitive advantage against others in their markets. They're looking for outsourcing as an option, a way to continue to enhance the focus on patient care without sacrificing the attention and expertise in revenue cycle, perhaps considering essentially building versus buying to maintain both of these focus areas. And we'll talk about this through all the co-managed, end-to-end, and strategic focus areas. A couple key things that outsourced companies could provide that may be especially difficult for independent health systems: advanced technology and analytics, essentially automated workflow and visibility and insight into, enhanced performance management systems, scaled and high-performing operations, access to industry-leading human capital, centralizing some of the functions, creating shared service environments, executing a global delivery model even, or rationalizing the technology or vendor footprint. These outsourcing firms can be focused on being a partner to the system, putting experienced, dedicated people, processes, technology on all components of the revenue cycle, while the health system focuses on patient care. After we get through these three proven plays for outsourcing, we are going to add in something we're essentially calling a bonus play. What you could or maybe should expect from a firm is added benefits through ways that they can reinvest in technology and make patient experience better by all the other revenue cycle work they are doing. Okay, like I mentioned, the first focus on outsourcing. Some of the key considerations that health systems are going to look into as they look to outsourcing. One is general, potentially, lack of visibility within their own health system today. Lots of disjointed infrastructure between, front end, middle, back end, vendor spaces, making it difficult to keep all the operations in check and operating as efficiently as they can. Those lead to suboptimal financial outcomes, and it's pretty difficult to get over that hurdle to connect all those systems to increase visibility. Difficulty scaling operations. Operations have to scale up for a variety of reasons, a payer market issue changes, system conversions, geographical expansions or acquisitions, essentially, right? You've taken on a new health system or a new physician group, and you need to figure out how to work across all those. Or expanding across the continuum of care. You've taken on a new kind of work, SNF billing or something new, and you need to be able to scale and perform all of those operations at the same or, better margins than what you're doing today within your current health system. Another challenge is the aging and disconnected systems. It's pretty difficult, just like we talked about with lack of visibility, when the technology you're using is slightly aged or potentially it's not connected to all the systems, it's difficult to optimize performance in that space. The last is something we're calling missing checks and balances, but essentially making compliance and best in practice processes a part of your daily life instead of a part of your quarterly or annual audit process. Getting to best-in-class revenue cycle performance means bringing operations to a daily basis. Are we hitting on all cylinders every day on every indicator? Before we get in specifically to co-manage, one thing to consider throughout this presentation is one thing that people might think about when they're looking at outsourcing is what it means for those employees and their mission and values of the independent health system. I don't believe that needs to be a deciding factor when you choose co-managed, outsource, or full outsource or outsourcing at all. The firm should be a trusted partner in all aspects of your operations, intentionally integrating both the health system's mission and values with the outsourced organization's mission and values to provide the optimal revenue cycle results and patient experience for everyone involved. We'll first go through co-managed outsourcing. Similar to a full outsource model with some slight differences for those that are maybe not ready for full outsourcing. These kind of health systems recognize the need for transformative change. They're choosing to bring on a partner, but they still want their own internal management and staff to carry out a large portion of the work. They want to enable key services and technology solutions from the partner while maintaining a good amount of control locally. They likely have many vendors and flavors of technology that are not integrated, and probably putting quite a bit of effort into coordinating the activities and tracking the outcomes of those vendors and technologies. And third, which we'll see through anyone that chooses an outsource arrangement, Financial improvement is key, and certainly, an underlying component of all these. More net revenue and collections faster. And also, while improving net revenue and collecting it faster, reducing the total cost of all those operations. And then again, improving patient financial experience and being ready for what we don't know yet, right? What's the next thing to scale? What's the next thing to change? Co-managed, people that choose co-managed might be interested in outsourcing, but might find it easier to position the decision and sell it internally when we choose co-managed and we keep local leaders, and also giving you kind of a try before you buy way into a full end-to-end outsource arrangement, a way to build a partnership and an arrangement with a key partner before you turn over your entire operations to them. Strategic goals would be to focus potentially local leadership more on patient care and use those qualified outsource vendor partners for the non-patient care functions. When you're choosing co-managed, you want to move in the direction of something like fully outsourced, but maybe you're not ready fully for that full outsource partnership yet. Like I've already discussed, you get, with a co-managed arrangement, you're going to retain local managers and infuse outsourced vendor managers as partners in that process. You are going to gain access to processes and technologies created and used by that outsourced vendor. So you're getting a whole host of experience and expertise outside of your local health system infused into yours. And one of the differences between maybe co-managed and some of the end-to-end is there might be a little bit more customization in a co-managed space, meaning when you don't go full end-to-end, you might choose what specific items you are fully outsourcing versus keeping in-house. Something like maybe you outsource coding because you have some local market constraints or issues with finding the right people and getting the right skill set, but maybe you keep your billing function in-house as an example. With that in mind, you're going to see cost improvement and revenue enhancement through a co-managed model. You have potential for gains and performance improvement. And what you'll see is moving into a full outsourced end-to-end arrangement, you would continue to see those benefits and likely greater cost reductions as you move to the full end-to-end relationship. So we'll switch to that one next. The key benefits of all of this outsourcing, right, is that you have, especially in the end-to-end space, mutually agreed to goals. They're the basis of the relationship as you move forward outsourcing, and they're the things that you're both keeping each other honest about. Are we on the right track? Are we doing the right things for both organizations? And it sets up the way that you choose to be paid as a vendor, or as a health system chooses to reimburse the outsourced vendor for their services. It provides the general framework for how we share risk and rewards. On slide 10 here, we go through some of the kind of key outsourced components: operating system, technology, delivery, analytics. I think a couple things to look at on here if you're thinking about outsourcing are, you might look at this and think, I have a pretty good operating system and I have a pretty good delivery model. I know how to do the work every day, and I think we're mostly doing the right work every day. Many health systems would probably say, I could definitely use some help in the technology space and the analytics space. Those are easy kind of first components of the outsource to say, I know that you likely have more access to technology, you've done this for a lot of other hospitals, what can you bring to me? And the same in the analytics space. What we'll talk about on the next slide really is for sure those two things. But what do you get that's even better from today in the operating system and the delivery space? You get in the operating system space a vendor that has done this across all sorts of health systems and payer markets, right? And as they've done this in lots of different spaces, they've come up with the best possible way to do it across the continuum. So somebody would come to you and say, I've looked at all the ways that you're currently doing things. Great news. Lots of them are the same way that we currently do best practice across our whole host of clients. And these other methods that we want to outline right now might be a little bit different than what you're doing today, but we think it can enhance outcomes, right? Drive faster cash, decrease AR, decrease denials, potentially just make a more efficient workflow process, less variance. So that's going to be a key component of going with an outsourced vendor, is all the experience and the expertise they bring to you in the space of the methods to support the financial outcomes. I keep wanting to say, do people have any questions? And I remember that I'm just talking to myself for the first 45 minutes. I have to remember that. The standard methods also lead into, how could I rationalize technology and vendors? How do I make sure that I have the right people doing the right work? The last thing on this slide I'll say is, when you get to the very last column on cost to collect, maybe one of the other differences between co-managed and end-to-end is really that fourth column on a lot of these. That cost to collect will keep being refined through this end-to-end partnership as well, because you get the most opportunities to get to all the standards, to get to all the technology, to get to all the automation and the process redesign that's offered with this vendor when they fully take over the revenue cycle operation. On vendor rationalization, this is one that should be pretty easy for people to feel the pain of, honestly. There's a lot of specialized revenue cycle vendors for you to engage with, and each of them provides a profile of what cash they're going to drive, what compliance risk they're going to solve, what subject matter expertise they're going to bring to your operations that maybe is pretty difficult to in-house. What you forget about during the first 8 to 10 vendor outsources, as you move forward to 50 or 75, is you have to manage all those file feeds. You have to remember what you've sent to every vendor. You have to somehow keep track of the effectiveness of each of those vendors. In the space of limited IT resources, limited project managers within your revenue cycle teams, increased security standards, and basically, as you keep growing that vendor pool, the complexity just increases dramatically. And I think now you become saying, did I send that accounts to vendor A or vendor B? Should they ever go to both at the same time? Am I getting what I wanted out of vendor A and vendor B? Should vendor B ever go in front of vendor A? All of those things become questions that are relatively easy for an outsourced vendor to rationalize and solve for, right? That outsourced vendor is designed to do revenue cycle operations day in and day out at the highest possible outcome and lowest possible cost profile, really. So what you get in that space is an outsourced vendor that says, good news, you have 100 vendors today, maybe we can get you down to 30. And that the difference between the 130, part of that is going to be, you don't even need a vendor anymore because you've chosen, this outsourced full revenue cycle vendor partner, and they do some of the work that you currently had to do all these disparate feeds before. And the second part is an outsourced vendor should bring to you what they consider to be the best-in-class vendor profile. They've done this work enough times that they now know which vendors should be used and how many file feeds should be transferred, daily, weekly, monthly to optimize performance. Before we get, sorry, I flipped back to the slide. I want to make sure I knew where I was. The last thing to consider, I think, is people ask about, what about the employees in an end-to-end outsourced model? How do they feel? Because as you remember, if you went to a full end-to-end outsourced model, one of the things the health system might benefit from is, all the payroll expense from a P&L perspective becomes the responsibility of the vendor partner, not the health system's responsibility. So that's a good win for the health system. And then the second part of that is potentially a balance sheet pick up a little bit from not holding pension liabilities within the health system. Now the vendor partner is going to hold those. But that may be a tough decision for a local health system. Even with those financial implications, they might say, I don't want that for my employees. I want them to be part of this health system. That's who they connect with. One anecdotal thing throughout this, and I mentioned this earlier, is is remembering that a vendor outsource partner should integrate and enhance your mission and values by bringing their mission and values along with yours, as opposed to thinking they're two disparate organizations. So keeping that in mind for the employees. And then the anecdotal piece on top of that is our own personal experience has been that we have had some employees that have transitioned say, I really like working for a company that their sole responsibility is revenue cycle. Very easy for me to see as an individual employee how my job matters to this organization. When a revenue cycle person sometimes is, a part of a health system that's focused on patient care, it's not as easy to necessarily see how that one individual revenue cycle employee matters to the overall purpose of the organization. We have heard some employees say, I actually have increased engagement, and it's easier for me to see how my job matters when they become part of a company that's fully focused on revenue cycle. With that in mind, I know I went through some of the co-managed and full end-to-end. The last thing we'll talk about is, what if I didn't want to do either of those, but I had a strategic focus area or a very specific need I wanted to address? What kind of trends or opportunities do we see in that outsourcing space? So I'm going to turn it over to Dan, and he's going to go through outsourcing strategic focus areas.
Great, thank you, Kate. Yes, Kate mentioned proven play number 3 is the outsourcing of specific strategic focus areas. And vis-a-vis the co-managed model and the end-to-end model, this is the smallest scale outsourcing strategy. And in simple terms, it's just the outsourcing of select RCM functions, but not obviously all. And we see providers going in this direction for a few reasons. In general, it can be a good strategy for people who are looking for a solution to an identified problem, and they may be looking, maybe prioritizing speed to value in a focused area over a more comprehensive solution. And it can often be an entree into more outsourcing down the road. It doesn't have to be. And even though it's more narrow in its focus, it can still include elements of risk sharing and at-risk components as well. But some of the main reasons we do see people going down this outsourcing strategy is a shift in organizational strategy. An example of this would be the push for modernity in the patient experience, for example. Redesigning the front-end patient access, that may be a new organizational vision that requires a strategic partner to help execute. The second main reason we see is there has been a specific identified problem area. A common example that we see in this space is revenue integrity and underpayments. This is an area in which the right partnership or the right strategy can yield additional net patient revenue quickly and in perpetuity as well. And the final would be as a way to react to a market trend like or an emerging payment model. And some examples we've seen in this going back a few years, ICD-10 was maybe one of these inflection points that healthcare organizations decided to move into outsourcing strategic functions in the coding and middle areas. We see this in the physician care settings with HCC and RAF, but it can be a very effective way to gather intellect and capabilities to deal with changing market trends. And so some functions that we see are fairly often, organizations will fairly often go to in strategic outsourcing situations would be coding, denials management and underpayments, charge optimization, case management and physician advisory services, and then billing and AR follow-up. And the reasons that we see these 5 services probably more than the rest, I guess a couple things. The first is I would say they are more commoditized. And so they've been outsourced for probably longer than some of the other revenue cycle functions. So there's a little bit of precedent, and there's even more global opportunities rather than just those available domestic from a labor supply standpoint. I would say the second reason is they're less visible to the patient. It's easier to make a switch in some of these areas because it's behind the scenes from the patient's viewpoint. They're scalable. They typically have great economies of scale. They have strong, clear ties to the balance sheet. And like the patient, there's less clinical tie-ins. Case management and physician advisory is the potential exception, and potentially coding, but they have typically less clinical tie-ins versus scheduling, for example, on the front end, which has a heavy component of that. And one of the areas of strategic outsourcing focus that we'd like to focus on is medical coding. And so we talk about this as a standalone service that healthcare organizations are turning to. And they're doing this because managing a high-performing and cost-effective coding operation is very challenging. It's challenging for a lot of healthcare organizations with their incumbent talent pool and capabilities to really run this effectively amidst a number of headwinds. And some of those challenges, which are not unique to medical coding, but they happen to have sort of a significant impact in this space. First is the declining revenue and more revenue moving at risk. And value-based reimbursement models are largely, not completely, but largely driven by middle resources, inclusive of coding. And so on top of the complex and changing rules and regulations around coding and CDI, it now has an increased tie-in with reimbursement, and the ability for an organization to document, clinically document, and then abstract coding off of those clinical documentation is now more than ever tied in to revenue risk. The second reason is, and this may or may not be controversial, but we typically see analytics in the middle space is generally underserved versus all other parts of revenue cycle. We see systems lacking the measurement tools and analytics to actually pinpoint real revenue prospects as it's being documented and coded, and also the right tools to actually manage coding and clinical documentation throughput effectively. And the lack of good analytics in this space makes some things that are very critical hard to facilitate. And one example is the execution of physician bylaws and medical executive regulations with physicians. Those can be really hard to enforce without good data. And that obviously impacts timing of claims, it impacts the quality of claims. The third area would be cost. And this is not unique, like I said, to coding, but this is an area in middle revenue cycle and coding in particular, where we're seeing spend as much as 50%. The spend within the middle is as much as 50% of the healthcare organization's total revenue cycle spend. Yet it's kind of one of the areas that's held on to the most in outsourcing decisions. A few reasons. Obviously, the labor to do the work in this area is highly certified. It is a premium compared to other revenue cycle functions like patient access. And the workflows tend to be complex, a little clunky. And so you have this rising cost to collect amidst higher labor costs, more complexity, and on top of that, you've got less analytics to manage the process. The fourth area we see is labor gaps. This is an area that's difficult, we see as difficult for healthcare organizations to control attrition. So we see high turnover, and we see that generally because of a strong, well, there's obviously macro level trends in the US now with unemployment where it is, but in particular with coding in the US being a work from home role, it's hard to build employee engagement and loyalty. The market's still very competitive out of ICD-10. There's a lot of supply. And the global labor dynamic creates a very difficult place for a healthcare organization to compete for good talent in this space. And then what happens is even the smallest gaps in labor create million-dollar problems in delaying claims in DNFB, but also rushing through claims and creating revenue risk. And then finally, poor outcome visibility. I touched on this with analytics, but this is an area where determining who is accountable for what in the production cycle is difficult. And various bolt-on technologies and EMR, computer-assisted coding, they may help the process, but often they can make the visibility into that process more murky as you're passing things from 3 to 4 systems just to get it from document to coding. Now, from our perspective, outsourced coding solutions can help improve outcomes and prepare organizations for the future as it relates to the middle revenue cycle. And so what are some of those areas? So some values to outsourcing medical coding that we see, first of all, is an improved ability to protect compliant revenue. We typically see better, or I would say a higher ability to invest in fund quality assurance at scale. You think about something simple like moving quality assurance from a quarterly process, sometimes we see it annually, to coding outsourced service providers, which are doing this daily, weekly, real time. Helping with the revenue protection is being able to tap into technology-enabled coding and charge capture solutions. Think about DRG validations, et cetera. And then broad industry expertise in the compliance area. People who live, eat, breathe, sleep, run coding guidelines and regulation changes. And oftentimes you can connect into a corporate compliance framework that helps protect risk. We also see the ability to improve analytics, not only through capabilities and capacity of churning out more reports, but the introduction of real-time daily dashboard technology. Probably more importantly, though, is the ability to broaden an organization's viewpoint of entitlement and benchmarks on specific clinical and coding-related processes. You think about the turnaround time on queries. How are my physicians doing, vis-a-vis another benchmark I want to pick in a similar geography? So this is something we see as a significant leg up gain from the outsourcing in this area. Lower cost, probably pretty obvious. Certainly global capabilities, being able to take advantage of arbitrage, the ability to get some leverage on your overhead through scale, centralization. Some other areas where we're seeing this help healthcare organizations who decide to partner in this area, access to capital funding around task automation, things like autonomous coding, and also the introduction of standards to eliminate waste. We also see the ability to enhance the talent pool. We talked about healthcare organizations struggling, maybe local or regional systems to attract and retain good talent. You broaden your access to the pool, more funding for training and education at scale, and oftentimes at no cost to the employee, which is a tremendous retention technique to be able to fund CEUs, credentialing, licensing all at no cost, helps build some engagement. And then with coding specific firms often, or middle cycle firms, you often see advanced career potential for the employees there, which help attrition as well. And finally, managing outcomes. Kate talked about this in sort of the end-to-end model. You're able to transition a payroll liability or a cost center to an organization whose economic structure with you can be based on performance, SLAs, and productivity. So those are the values that we see and what we believe is a exceptional business case and use case for outsourcing coding on a modular basis.
One of the other modular opportunities is revenue integrity. Broadly taking charge capture, pricing, charge reconciliation, all into the space of revenue integrity. I think there's a lot of vendors out there right now that are very focused on net revenue improvement. So, charge capture, DRG coding work, like Dan talked about. One of the trends I think you're going to see more of is charge variance monitoring. What happened when I went through that system conversion? I need to sign a new contract with a managed care payer, and it's much more specific than my contracts have been in the past. How does my charging translate into how I'm going to be paid in the future? And at the same time, hey, I have to decrease my staff locally, but I need better outcomes in spite of decreasing staff. So I need somebody to be my partner to build me some very targeted logic that helps me make sure that I've captured all my gross revenue for my clinical departments that rely on it for a productivity perspective, but also efficiently and effectively captured all the net revenue that I'm due from all the various payers that constantly change the rules on me. And I need all of that at the right cost and the right time because I don't have the capacity to do it. All of that, any outsourced revenue integrity vendor should be, bottom line, everything should be around compliance. Are we always following Medicare rules? Do you have good processes in place to make sure that you're following all the rules in both your Medicare, your Medicaid, even all your managed care contracts? They all have their own rules as to how something's supposed to work. So getting somebody that understands clinically how you capture charges in the middle space, how you code those accounts, and then overlays that with how do you bill those accounts and how is your payer going to process those bills. That's all part of revenue integrity, and something that we're seeing as a trend is somebody that really understands all those components together, along with, like I said, the next level. Even if the charges are only a productivity based, or I just need to make sure that I'm looking at stuff the right way as I've gone through the system conversion. We're definitely seeing that as another focus area. My personal experience at our firm has been, this is something a lot of people look for. There's a lot of vendors in this space. Key considerations might be how fast can that vendor drive cash to your organization? How easy is it for you to pass data along to that vendor if you needed to? And how easy would it be with that vendor for you to customize rules or come up with new opportunities or new way you want their technology to work with your internal team? I think those might be some of the considerations as you consider strategically outsourcing something like a revenue integrity component. To wrap up today, we're going to go through our bonus play. Like we said, if you outsource to a vendor, what's something great that vendor could provide to you that's an indication that they're reinvesting in technology and helping you, advance your space in your local market. So Dan's going to walk through the bonus play on patient experience.
Thanks, Kate. Yeah, for the added benefits of outsourcing in terms of the ability to improve the patient financial experience, I think initially when many people think of business process outsourcing in general, and you apply that in a healthcare setting, it probably seems counterintuitive to say, hey, a positive externality of that is improving the patient's financial experience. Because this is probably something that's core to the mission of the health system, and so by then distancing themselves from that, or by moving that down the chain to a revenue cycle management or in an outsourced setting, it would seem to suggest that, well, the mission would be further diluted as patients interact with people who may not be employed by the health system, et cetera. But what we're actually seeing is a completely different trend. It's actually a positive improvement in the patient experience through outsourcing with the right partners in the right way. I think probably to start this off, the first thing is that it probably comes as no surprise to people that this is a big problem or opportunity, depending on how you look at it. We recently conducted a survey of hospital revenue cycle leaders, and it was 41% of the hospital revenue cycle leaders that we surveyed ranked patient experience as their #1 priority for 2018. So it's sort of becoming a bigger and bigger topic of conversation, and probably somewhat clearly to the folks on this phone, but the rise of consumerism in the space has been huge. High deductible health plans have moved more of the liability to patients, and with more money owed on a per claim basis, they're treating these interactions more like a consumer. And that drives them to want certain things: transparency into the prices, more convenient ways to pay and engage with the provider as they're used to in all of the other consumer experiences that they have in their day-to-day life. And so here's why we see the patient experience improving as you move toward a revenue cycle outsourcing model. I think it starts with the current approach. We talked about the patient has consumer expectations. They've been retrained in the terms of how they think about interacting as a consumer. And the historical process has been financially driven. What are my authorization rates? What are my insurance verification rates? They're outcome metrics of a process, or maybe they're in-process metrics, but they're a hop, skip, and a jump away from the patient satisfaction. On top of that, current technologies are not well applied or really integrated. And what I mean by that is a lot of people have online bill pay, but I bet very few patients that view the online bill pay portal probably view that with the same level of convenience that they do their banking applications, for example. The limited modes of patient communication and prioritization, it's heavily still phone call dependent. In the incumbent process, it is a lot of phone calls. If you're a patient and you schedule a procedure, you may get 3 phone calls before you come in. One from the nurse, one confirm your insurance, one to check on your authorization. So it creates kind of a burden that does little to put the patient in a more convenient path to service. And a lot of brute force. Patient access has historically been an area where you solve problems by adding more people. You have wait times, you add people. You're not able to verify all of your authorizations, you add more people who can. And so the heavy staffing may help close some acute gaps, but it doesn't necessarily correlate into a better patient experience. Converting this to outsourcing, what we typically see is a set of standards and methods which will rebuild the front-end process from the patient's and physician's perspective. Also, the ability to leverage modern technology and a user experience and a UI design that feels and looks and operates more modernly, more effectively. And then we also see the outsourced approach being able to better engage, better support, and better serve patients from intake all the way through final bill. And some of the areas we see on the engagement, making it easier for providers and patients to collaborate, improve the healthcare experience. Some examples may be additional payment options that become that are a byproduct of outsourcing a component of the RCM function, as well as the ability to leverage better technology for more accurate pricing transparency and price quotes. From a support perspective, additional trained outsourced RCM staff, and also the ability to gain access to large capital investments like telephony services that can help improve call center capabilities. And then from a service perspective, this is where you're still able to get scale, but scale in a way that can still be personalized from the consumer's viewpoint. We see the ability to lower patient wait times, deliver higher patient yield, and through investments and capabilities of things by, for example, being able to tap into multi-channel patient contact devices, tablets, kiosks, mobile apps, you're creating a more loyal, a more happy patient base, and as a result, hopefully healthier. And then from a financial standpoint, we've seen in our own operating experience, but also in some industry studies, that a patient who's better educated and a patient who trusts and is satisfied with the billing process is more likely to pay more of their share. So those are some of the benefits that we see from the patient experience as it relates to revenue cycle outsourcing. In closing, we've spent the last, about 43 minutes talking about the value of outsourcing for healthcare organizations. A little bit about us, about R1. We are an independent provider of end-to-end revenue cycle solutions, one of the leading providers in the country. We have experience in end-to-end revenue cycle outsourcing, as well as co-managed and modular solution engagements. Today, we have about $31 billion of annual net patient revenue under management and about 15,000 employees. And what we feel like is a unique and best-in-class infrastructure that we've enabled on a differentiated technology platform. And as a result, we've been able to drive a very strong track record of success for our clients at scale. We are operators at heart. Kate and I are operators, and obviously we're here on the call today. And this company, in our roles, we believe we build our standards, our methods, our technology based on deep day-to-day operating experience in the trenches. That's kind of how we build those up. In our solutions, a little bit about those. So our portfolio of solutions is HFMA peer review certified, and our patient financial platform was recently recognized as the best new solution by HFMA at their annual conference in June. And what that signals from our standpoint is a focused investment and also a desire to partner with our customers to improve the patient experience when they outsource their revenue cycle to R1. Our mission as a company is to be our customers' one trusted revenue cycle partner to manage all facets of the rev cycle and allow them to achieve new levels of patient care and also ready themselves for the future. We are always looking to connect with potential partners that may find value in our solutions, so please do feel free to reach out to Kate and myself. We thank you very much for your time.
Thanks, Dan and Kate. That was a fantastic presentation. We will now begin today's question and answer session. As a quick reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try to get through as many questions as we have time for. So it looks like we've got a lot of questions rolling in, so we'll go ahead and start with the first one. We have an audience member who says, if we did outsource, how would it help integrate revenue cycle? That part still escapes me.
If we did outsource, how would we integrate revenue cycle? I think how would we, I would say Dan and I are a good example of that sitting here. We spend time every week talking about how we integrate the middle and the back end of the revenue cycle more closely, right? The opportunities with an outsourced vendor partner are to take the disparate parts of revenue cycle functions and make it more fluid and better outcomes throughout the system. So how would you do that? I guess I'm trying to think of how succinctly to say this. I guess for us, I'll just use my personal experience. We know that that's our job to do that. So Dan and I spend time weekly talking about how does coding and billing relate and how could we get better outcomes in the denials management or the yield space by having coders and billers know more closely what they're doing and how their roles affect each other.
Yeah, it's a great question. And I think with our experience as sort of an end-to-end revenue cycle provider, we've always found there's more value achieved through optimizing the process as a whole versus optimizing each process individually and then working a connection point between the two. As it relates to potentially coding and billing, for example, if you're running coding as effectively as you think that you can be, but you're not attentive to billing first pass clean claim rates and the quality and volume of things going into the billing scrubber, as an example, then coding may be running effectively, but you may not be optimizing the number of touches that you're creating throughout the revenue cycle as a whole. And as an end-to-end provider, our incentives, frankly, are on only touching an account when we absolutely need to, by risk, by necessity. So I would say that's probably the other value, or how we do that is by resisting sort of the myopic view of optimizing each process individually and instead looking at each process's output as the input to the next step and optimizing as a whole.
Let's go with Dan's answer on that one.
Thank you. That was a super helpful and thorough response. So our next question here is about revenue cycle priorities. So this audience member asks, in your opinion, what do you see as the biggest priorities for revenue cycle in the immediate future?
Dan's backing up. I think it's a buzzword right now, digitization and automation, right? So how does that advance my revenue cycle? I think the opportunity is to make sure that that's a tool in your toolkit and you understand how digitization and automation may transform your revenue cycle output from a cost management perspective, maybe a quality defect perspective. So I guess I see that as an opportunity. More closely with what I look at every day, I would say denials management. And we actually focus a lot right now on denials management we know that education is a component of that, right? Changing behavior throughout the revenue cycle to lead to better outcomes in denials management. But I think one of the opportunities for us is to consider working, like we just talked about on that last question about integration, on what else can we do when we've gotten denials. What different way could we skin that to figure out how we change the outcome on some of those and reverse the trend on, really stringent payer requirements and opportunities for payers to deny wherever they can to at least delay cash for us.
Yeah. Only other area I would add over the next, the next near term 1 to 2 years would be pretty broad, but I would say the middle revenue cycle as it relates to CDI in particular. We touched on this a little bit before. It's a lot to unpack in that area, and it's a lot to unpack. Typically, if you're may not be comfortable in some of the more clinical facing components as it relates to physician documentation, et cetera. But I think we see a big opportunity for technology and for process redesign to help improve outcomes in middle revenue cycle, because it's like we were saying, it's so sensitive to getting the right compliant revenue, and more is going to go at risk, and more is going to be based on what you code. Specificity will continue to increase. APR, DRG, we're already seeing that around getting the right severity of illness and risk of mortality. And that is an incredibly, I think, important area, and it's growing in importance. And on the technology side, that's an area where things like CAPD, or computer-assisted physician dictation, we're seeing technology that's beginning to address that in terms of assuring clinical documentation is at the right specificity up front. But there is a long way to go. I think a lot of help and a lot of additional investment and attention needed in that area.
Thank you so much for laying out those priorities for us. So our next question gets at something that Kate just mentioned, but an audience member says they've spoken to countless consultants about AI, digitization, advanced analytics, et cetera, and they still don't get it. Why are those needed other than simply being buzzwords today?
I think they're needed because the margins keep tightening. The ways that we get denials keep advancing. The specificity to which we need to code and evaluate, defects in the process becomes more and more specific. We're not looking at broad trends anymore. We're looking at trends in the, tens to hundreds of accounts instead of thousands to tens of thousands of accounts. So in my vantage point right now, I would say that digitization, automation, all the buzzwords that you just said, take your organization from great to really great. And that's about where you have to be right now with the margins and the way that the market's moving. And in addition, every time something changes and Medicare comes out with a new rule, or you sign a new contract and it's worth, a percentage point or a point of a percentage point less than what you used to have, it's all on you to make your process more effective and drive the same amount of cash out of that less lucrative contract or environment. So digitization, automation, advanced analytics help you pinpoint the next area of opportunity.
Yeah, and the only thing I would add to that is, I kind of give the eye roll too. A lot of times I'll hear those and I'll say, okay, it's just a way to kind of sound smart. It's like saying Bitcoin or blockchain or something. Mm-hmm. I think the goal of them, though, is really to take the highly skilled people that you have and put them on the hardest problems. Because right now, a lot of the highly skilled people that healthcare organizations are employing, they're doing very transactional work. And it's tough. You really can never get ahead of the transactional work and focus on the truly strategic or complex things, because you've got a rock pile to clear every day. And I think the thought is, whatever vehicle you want to use, whether it's AI or RPA, machine learning, whatever the vehicle, the destination is still the same. Right. You get your people, and your people need to be doing, free them up to do the things that are really strategic for the organization.
Perfect, thank you. That was super helpful. So our next question is about defining the revenue cycle. We have an audience member who asks, would you please redefine what components of the revenue cycle you include in the middle?
Yeah, so middle more broadly, so what we consider to be in the middle would be transcription, HIM operations inclusive of assembly, analysis, other HIM functions like ROI, those would be in scope, so HIM, coding, obviously, CDI, and then in our middle, we have sort of included as a proxy revenue integrity and charge capture, as well as our CDM services, which we also have run our CDM for our end-to-end clients as well. So transcription, HIM, coding, CDI, CDM, charge capture, and revenue integrity.
Perfect. Thanks so much for clarifying that. Our next question is, what structure have you seen for a complete end-to-end solution in terms of who manages the relationship, and how does your company coordinate with the finance accounting team?
Well, let me answer the second one first, and we can think about the first part. The integration with finance is important, because a lot of times we'll see the operating metrics on work in progress, on AR days, it's not always completely tying in with what is posting on the income statement. So what we typically have are relationships that exist at the per client level with a relationship manager that's typically the peer to the VP of Rev Cycle at that institution. So we sort of have a peer to that person, and they're participating along with other members of our team in the monthly close calls and pre-close calls. So if there are things that necessitate booking an accrual or certain trends that we're seeing with payers that's holding up a significant amount of AR, we actually engage on those every month. And what we do is we prepare, for some of our customers, we compare a month close summary. The month close summary is actually an input of the pre-close and close calls, which is a comprehensive revenue cycle summary of AR, DNFB, operational denials, clinical denials, aged AR, a few other metrics. That summary, gives period over period changes and also absolute changes, and that helps to inform finance of kind of what's going on in revenue cycle and why it matters for them. I kind of answered the first part on the engagement, but I would say that we typically have a structure that's, like I said, a relationship manager that's a peer to the VP of Rev Cycle.
Thanks, Dan. It looks like we have time for just one more question. So our last question from the audience is your focus only hospital, or do you have medical group clients as well?
It's both. Capabilities, both hospital care setting as well as physician care setting as well.
Perfect. Thank you so much for clarifying that. So that's all the time we have for today. I want to thank Kate, Dan, and R1 for the excellent presentation, and thank you to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.